Good morning, everyone. I'm Kimberly Chalia with PHCA. Thanks so much for joining us for today's webinar. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for one continuing education credit for all PHCA members in attendance. For those who provided a NAB number, credits will be uploaded within the next 3 weeks. We'll also share certificates with those in attendance. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions using the chat icon at the bottom of your screen, and we'll make sure to answer as many of those questions as possible at the end of today's presentation. Now I'll turn it over to Sophie Campbell.
Thank you so much, Kim. Good morning, and thank you for allowing me to spend some time with you this morning. Our topic for this morning's education is why nursing home management should be interested in restorative nursing programs. We're going to make the business case for restorative nursing programs. It never sounds like when you talk about a nursing program that there is a business case, but there truly is when we talk about restorative nursing. So let's start out by talking about what restorative nursing really is all about. Restorative nursing programs are nursing interventions. They're not therapy. They're not required to have therapy involved with them, but they are nursing interventions. They're like putting on heel protectors or elbow protectors or turning and repositioning, but elevated to a higher level. And these nursing interventions promote the resident's ability to adapt and adjust to living as independently and safely as possible. So what that means is we're all living independently and safely, but when someone has a stroke or someone has a traumatic brain injury or someone has a hip replacement or a knee replacement, there are changes to what they're able to do independently and safely. And restorative nursing helps the resident to adapt, helps them to figure out what it is I need to do differently and how I need to do it differently in order to be as independent with my own mobility and with my own self-care and to be as safe while I'm doing those things. It also actively focuses on achieving and maintaining optimal physical, mental, and psychosocial functioning. If that sounds familiar, it should. It's in our state operations manual. It's under F684, which is quality of care. This is really what we're being asked to do under F684, quality of care. So it assists our residents not only to achieve that level, but also to maintain it. And if you're thinking, well, wait a minute, I know we have some restorative maintenance programs, or I've heard about restorative maintenance programs. Absolutely. Those are considered restorative programs as well. Restorative nursing is resident focused and resident centered. And again, if we think about F684 and many other of our regulations that talk about resident rights and our care plans that require us to be person centered and resident focused and resident centered, restorative nursing allows us to do that. But while it's focusing on functional mobility and self care, we can be very resident focused and very patient centered. So what are the restorative nursing programs? There are many restorative nursing programs out there. You can see them all on the screen. So what we're not going to go through each one of these because I could spend a lot of time talking about this. But when we talk about restorative nursing, what I'm going to say is it's a program, but it's also treatment services. So when we talk about therapy and their treatment services, and we talk about wound treatment services and other treatment services that we have in place for our residents, as we talk about restorative nursing, we should refer to them as treatment services as well, because these are treatments for our residents. And we need to elevate restorative nursing to that level and not just see it as, well, if we have time, we'll do it. If we don't have time, oh, well, that's the thing that's going to be taken out of the day. They are treatment services and they're important for the resident. And if you look at this list, you can see the things that are listed under restorative nursing treatment services, and they're important. Having range of motion. And we're going to talk a little bit more about these and how these lead to clinically they're important and clinically they're good for the resident. But we're going to also talk about the business case for why these are important in a facility. But again, transfers, ambulation, being able to eat and swallow, these are important communication. Think about if you couldn't do these things. We can do these things, maybe not splint and brace or amputation and prosthetic assistance, but think about if you couldn't toilet yourself, if you couldn't do your own bed mobility. that would limit you significantly and you would feel like a burden. And that's what our residents feel. So let's talk about a little bit more about the positive impacts of restorative nursing. So it helps our residents to increase their mobility. What are the benefits to that? Well, clinically, there's a lot of benefits to it, but what are the benefits from a business case? Why does management care about that? Well, it reduces contractures. If our residents are mobile and they're moving those joints and they're moving their arms and their legs and their fingers, it reduces contractures and the need for splints. And splints either have to be purchased or they have to be fabricated by therapy. Well, it's a good thing if therapy fabricates them from the standpoint of we can bill for therapy's time. But if we're purchasing the splints, yes, therapy still should be involved because they should be fitting the splint on the resident and making sure that the splint is doing what it should be for the resident. But also, if the resident's contracted, we're going to have to increase how much pain medication we provide the resident. We're going to have to decrease what the resident's able to do. We're going to have to increase the amount of staff and the amount of staff time that we spend with that resident because it's not as easy for them to move and do the functional mobility and self-care items for the day. Reduced pain. So this is both contractures as well as other things that can happen if their mobility decreases. So they're going to have, if we use restorative nursing programs, we're going to reduce the residents' pain. They're mobile, they're moving. If you've ever had surgery, you've ever had to be in bed for any length of time, getting out of bed is painful. Sometimes getting out of bed when you have arthritis is painful. And we hear that from our residents. But if I'm getting contracted or if I'm not moving and I've been bed bound because I don't even move in bed and I've been bed bound for a while or chair bound for a while, then I start to have more pain. This increases the need for pain medication. And what are the adverse effects that we can have from pain medication? So let's think about some of these. A tramadol or Oxycontin, we can lead to falls because the resident's not as oriented and it changes the way we think. If you've ever been on tramadol or Oxycontin, you know that it kind of changes the way you're looking at things, kind of changes your perception a little bit. But falls can be one of the adverse effects, and the cost of falls is significant. Many studies have been done to talk about the cost of falls. Reduces the potential for pneumonia. If our residents are more mobile, they're less likely to get pneumonia. And pneumonia increases the opportunity for us to have to readmit the resident to the hospital. And if we have to readmit the resident to the hospital, again, this is more work for our staff because we're sending them out of the facility. We're having to call the ambulance to send them to the hospital. We're having to tell the family that the resident acquired pneumonia while they were in our facility. They're coming back, possibly on IVs, on a change in medication. They're possibly disoriented, which can lead to the adverse effects of the resident falling. So we're looking at all of those adverse effects and what are the costs of those to our facility? Certainly, hospitalizations, we're not paying for those. The hospitalization is being paid for by Medicare or whatever the resident's insurer is. But if we look at our managed care dashboards, and when we talk to our managed care organizations and they look at the dashboard, they're comparing your number of rehospitalizations with other providers in your area and in the state and what their level of rehospitalizations is. And if you have too high of a level of rehospitalizations, they're going to look at you and say, do I really want to have you in our contract? Do I really want to have residents come to you or patients come to you from the hospital to be your residents? So it does impact us in a lot of different ways. Also at the hospital, they're looking at how many times are you sending residents back? How often do the residents come from your facility to our hospital with pneumonia, after a fall, with a pressure ulcer? So they're also looking at that, and the case managers are looking at that as well. Looking at the use of antibiotics and how expensive are some of these antibiotics. If you haven't looked at your pharmacy bill recently, take a look at it because some of these medications are really increasing in cost. And let's just take that into account in terms of what can happen at the hospital. And sometimes when we think about sending a resident to a hospital, I've heard some infection preventionists say, oh, you don't want to go to a resident. You don't want to go to the hospital because bad things happen there. A lot of infections can happen at the hospital. Well, absolutely they can because it's a different environment. We think of a hospital as a very sterile place. It's not. Your roommate, you don't know what your roommate's going to have. Sometimes they don't know until already both residents or both patients in the same room have acquired that same infection. So when we think about that, some of our antibiotics, and I know that there are a couple of them that are out there now that are $5,000 a dose. And you have to think about that when that resident comes back to you. How much is that going to cost you now? Not for pneumonia, but for other things, there are antibiotics that are very expensive. So we want to look at the cost of what it's going to cost us to deliver these antibiotics. And if they're IV antibiotics, that increases the workload for the nurses. It increases the fact that we're now using tubing. We're going to have to get the IV medications. We're going to have the IV fluids that the medication is going to run through. We're going to have that PICC line that we're going to have to flush. We're going to have the dressing over the PICC line. So again, it increases our costs significantly. It decreases if our residents are mobile, it decreases the number of bed-bound and chair-bound residents that we have in the facility. And again, think about bed-bound and chair-bound residents, how much work they are for your staff, and how much of this immobility can continue to increase if they're bed-bound or chair-bound. As well as the decreases their depression, because now they're mobile and we don't have to put them on the medications. So we're looking at this depression in two different ways. If our resident is mobile, then they don't need to be on the pain medications, which can lead to depression as a side effect, but also they're mobile and they're not as depressed. If you talk to residents who aren't moving, they say that they feel badly, that they're not able to do what they used to be able to do. They feel like a burden. They feel like nothing. They wish that they were dead. That leads to depression. And then what do? We treat the depression. And what happens as an adverse effect from some of the medications with depression? It can lead to some other adverse effects like falls. We've already mentioned rehospitalization. So just to talk a little bit more about a few things that I haven't mentioned, but the positive impact on your value-based purchasing. So if you're not readmitting residents back to the hospital within that 30 days of when they were discharged from the hospital, then your VBP, you don't have that reduction in your Medicare reimbursement. The hospital's happy also because they don't have the reduction in their reimbursement either. So both sides are looking at that and saying, okay, if we don't readmit within the first 30 days, it's a positive for both sides. It's a win-win. Again, managed care organizations and their dashboards. The positive image that you have with the hospital discharge planners and case managers, because you're not sending the resident back frequently because of these adverse effects, because of the falls from the medications, because of the falls, because of the immobility, because of the pneumonia, and so forth. The reduced opportunities for resident disorientation. If you've not talked with your clinical staff when somebody goes out to the hospital, not only can they come back with an infection that they didn't leave with and medications that they didn't leave with, but they can also come back with disorientation. And this is especially true of anybody with a diagnosis of dementia or Alzheimer's disease. They just got reoriented to your facility, or they've been oriented to your facility for the past 5 years, 10 years, and then they go to the hospital after a fall and a fracture or a dislocation or a pneumonia, and they go to the hospital and they're disoriented because they don't recognize the place. Or if they're in your facility for less than 30 days and they haven't really acclimated to your facility and they go to the hospital and come back, they're disoriented. What does that lead to? Frequently, it leads to falls. Frequently, it leads to fractures. Frequently, it leads to dislocations because when they fall, they have these injuries because they're disoriented. They don't remember their bed being over here. They don't remember where the bathroom was. Aren't they supposed to be using a walker? Why can't they get up? They remember back when they were at home. Also decreased workload on the staff. And if we think about how busy our staff are now, if we think about the staffing crunch that we're in, the workforce crunch that we're in, and we're looking at all the paperwork and all the time it takes to do the transfer and the readmission. So on both sides, there's a lot of extra work for the staff. So decreased lengths of stay for our skilled residents. So if you're thinking, wait a minute, we can't do restorative nursing with skilled residents, we can. And we're going to talk in a little bit about PDPM and that restorative nursing is included under PDPM. But just to talk about where it fits in with skilled residents, adding restorative nursing to your resident care plan and to your resident care for your skilled residents prevents losses. Think about your residents, and it kind of ties in with the next bullet point as well. Think about your residents who come to the facility after a hospital stay and they're getting ready to discharge to home, and they go to therapy, 1 hour of PT, 1 hour of OT, and then they don't have therapy and work on those compensatory strategies until the next morning. What have they done in between time if we've done everything for them? And sometimes we hear that from the residents. I work in therapy and I'm not going to work for nursing. I want you to do everything for me. But we want restorative programs for them so they can, quote unquote, practice what they were doing in therapy. Therapy is going to set up that program. I know I said earlier that this is not a therapy program, but therapy is going to set this program up because most of our skilled residents do have rehabilitation therapy. So therapy is going to set the program up so it is a practice. So it is a follow up or a follow through of what they were working on in therapy. This also gives us in nursing the opportunity to observe the resident at all times of the day. So therapy sees them at 10 o'clock in the morning for PT, 11 o'clock in the morning for OT. That's a great time. How do you feel at 10 o'clock in the morning? You still have that Red Bull going for you with those 6 cups of coffee that you drank, and you're still going. By 6 o'clock in the evening, you're starting to wind down a little bit. So if we're doing transfers at 6 o'clock in the evening, or 8 o'clock in the evening, or 10 o'clock in the evening, or 2 in the morning when the resident wants to transfer to go to the bathroom, how do they look? How much help do they need? How different do they look from what therapy said they look? How different do they look from what day shift and evening shift said they look? And this is what we need to tell therapy. So they need to see the resident in that environment, or at least as close as possible to it, so they can see what happens to the resident when they're tired, when they're getting up at night and they need to go to the bathroom, because that's going to happen at home. It gives us the opportunity to observe the resident in real life situations. So situations, they're rolling in bed, not on a mat. What kind of a mattress do they have at home? Do they have a big mattress? Is it a queen size bed or a king size bed? Or are they going home to a double bed or a twin bed at home? We don't know, but our bed in the nursing home in the resident's room is more of a real life situation, on and off the toilet, where they're having to take their clothing down and pull their clothing back up again and do toilet hygiene. Those are real life situations, and getting the resident ready to go home, and we can see what help they need. And it's a positive image for our managed care dashboards because we send those residents home sooner. We gave them the opportunity to practice those compensatory strategies that they're working on in therapy. And we saw that they could do it 24 hours a day. It also helps your residents. Restorative nursing helps your residents. And this doesn't have a really strong business case, but it does have a really strong resident and person centered case. So I have to always talk about this. It helps your resident from feeling like they're a burden of care. So when we look at our residents, and how many times have you heard, how many times have your staff heard when the resident says, oh, I've had pain since 8 o'clock this morning. I haven't asked anybody for anything because everybody's so busy. I don't want to be a burden. The more the resident can do for themselves, the more the residents involved in their own care, they don't feel like as much of a burden. What does that say to our staff? When our staff have the residents who are doing more for themselves, what do your staff say to you? We love those folks who come in with just a fracture because they're able to do more for themselves. I don't have to bathe them. I don't have to dress them. I don't have to shave them. They're able to do these things for themselves. Oh, and then we get the resident who had the CVA, and now they have their right side is impacted and their right side dominant. Yes, I have to do way more for them. So when we're looking at that, the more the resident can do for themselves, the better they feel, the better your staff feels. We decrease the workload on the staff. We also decrease, again, the residents' depression and the medications we're going to use for the depression, as well as the adverse effects of those antidepressants that we're going to be using. They're able to participate in their own self-care. And again, they can tell us what they want to do. They can tell us what's important for them and how they want to do it. So we're not doing it in the way that we've been taught to do it, or the way is easiest for us. They're doing it the way they want to do it. It increases the potential for them to ask for help. The more they can do for themselves, the more likely they're asked to ask for help in the things that they're not able to do for themselves. The resident who can wash their face and hands, the resident who can do toilet hygiene, the resident who can shave himself, the resident who can do his upper extremity dressing. When he needs help to get out of bed, that's the one thing he's going to ask for help for. He's going to do it because it's only one thing. It's not, I'm a total burden and I have to have help with everything that I'm doing. And it also reduces the potential for resident abuse and neglect. When our staff are burdened, and if you look at any of the documentation that's out there and studies that have been done, even look at the regulation F600, when we look at that, The residents who are most likely to be abused or be neglected are those that need the most help because we spend so much time with them and they need so much help. They're the most likely to be abused and neglected for many, many reasons, but they are on that list. We've talked about the reduced workload for your nursing team members. How do we retain nursing staff? How do we retain our staff in our facility? We make it as good of a place to work as possible. We make it as nice of a place to work as possible. We look at their workload. Yes, your staff are going to say to you up front, what do you mean you're reducing the workload? I'm having to do all this stuff with restorative nursing. It's a treatment. You've been telling me it's a treatment. That's extra work for me. It's additional treatment. Yes, it is. But when we look at that, the results of that treatment are going to lead to the resident able to do more for themselves. So again, let's start with the resident's depression. The resident's able to do more for themselves, so they're less depressed. I put in air quotes here, or I put in quotes, I'm doing the air quotes, that they're easier to provide care for. It's so difficult. And those of you who have done it, you know it. When you go into the resident's room in the morning and I'll just go with giving them medication. Hi, Joe, I'm here to give you your medications. I don't need my medications. I want to die. I wish I was dead. Just close the door. Don't even come back in the room. Just let me die in this room. And we've got to talk him into being more happy. And we've got to talk him into taking his medications and having something to drink and going to breakfast and getting up in the morning. It takes a lot longer and it's more difficult to get them through the day. And by the time your shift is over, you feel like you've been carrying a burden on your back because you've been working with so many depressed residents. But also, as we look at the resident's functionality increasing, our staff can multitask. As the resident is shaving himself, the nursing assistant can empty his wash basin, can start making his bed, can put ice in his water pitcher. Other tasks that need to be done for the resident. So they're multitasking because now the resident is shaving himself. Yes, we're still in the room and we're watching him shave, but as he's increasing functionality or she's increasing functionality, they can do more things at the same time. We can also start triaging that restorative program. So now the resident is they're able to wash their face and hands. They're able to do toilet hygiene. They're able to shave themselves. Okay, what's the next step? What else do they want to work on? Do they want to work on upper extremity dressing? We're just going to keep assisting that resident. When do we get to transfers? When do we get to walking? And we keep assisting that resident and ensuring that they're increasing their independence and their safety with all of these functional mobility and self-care tasks as much as possible. It also increases the opportunity for nursing and the residents to work together. So let's keep going with some positive impacts. Increased Part B reimbursement. Well, how does that happen? When I said early on that the Restorative Nursing Program is a nursing program, therapy is not required. It is not coordinated by or overseen by therapy. Well, I just mentioned a little bit there that therapy can refer to the Restorative Nursing Program. And I would recommend that therapy does refer to the Restorative Nursing Program. But let's talk about how we can get this Part B reimbursement increased in there. This is a good thing because we're billing for Part B and we're going to be able to get that increased reimbursement. And sometimes we look at our Part B caseload that our therapists have and we think, how can we increase that caseload? We have so many long-term residents. Why isn't their caseload higher? Well, when we get restorative nursing and therapy working together, it is going to increase their Part B caseload. It's going to increase the referrals to therapy. Why is that? Because as we're doing restorative nursing treatment programs, we're looking at very closely what's going on with the resident in terms of functional mobility and self-care. So we're looking at the resident not just as okay, I transfer the resident. I'm going to keep transferring the resident. What's the difference? I'm transferring the resident. But now I'm doing a restorative transfer. So I'm taking a little bit more time and I'm walking through that transfer a little slower and I'm helping the resident through that transfer. But now I'm noticing things like, well, why did it feel like he was more of a burden on me when we were doing that transfer? Because his knees are buckling, his ankles are buckling. I need to refer to therapy. When I'm doing that transfer, the resident is now forgetting the steps of the transfer. Maybe he needs to be referred to speech because he's not able to sequence steps in activities that he needs to do. So we're looking at it more closely with restorative treatment programs, and then we can refer to therapy, which this also gives us the opportunity to specifically discuss what's going on. So it's one of those things where, okay, I know now that the resident is having difficulty with his transfer because his knees are buckling. Therapy can work on that. If I just say the resident is more difficult to transfer, therapy is going to say, well, I don't know what you want me to do. I don't know what you want me to work on. But if I'm really working through that transfer, as I do with restorative nursing, I'm going to see that. Or ambulation, that the resident is leaning too far forward over his walker, or he doesn't know where to place his walker. He is placing it too far in front of him, or the resident is having a shuffling gait and he's getting his toes caught in the pant leg of his other leg as he's walking. So we're noticing those more because we're focusing in on it with our restorative nursing treatment programs. Again, they're performing the compensatory strategies that they learned in therapy. If we go with skilled therapy, that's a follow-up, that's a practice opportunity. If we go with long-term, when therapy has completed, Part B therapy has completed, those compensatory strategies, we should be continuing them with restorative nursing. It's not a one and done. And those of you who remember, those of you who were doing this in skilled nursing or in our nursing homes about 10 years ago, there was actually a study done by the OIG. And I remember that study very clearly. The OIG looked at it, and what they were seeing is residents, long-term residents who were sent to Part B therapy, and then CMS reimbursed the facility for that Part B therapy. The residents had no change in their ADLs. They had no change in their functional mobility. They had no change in their self-care. Now, when you're saying, okay, well, then that's a therapy problem. Therapy discharged them being able to do whatever we referred them to therapy for, or at least being able to do it better and more effectively than what they did it before. What happened was when the resident was discharged to nursing, there wasn't that transfer. There wasn't that education for nursing. There wasn't that referral to a restorative nursing program. So nobody carried on those compensatory strategies. Nobody carried on what was being worked on in therapy. So the resident just went back to being a two-person assist, just went back to being a mechanical lift transfer or a sit-to-stand lift transfer, or the resident being fed at meals because it's faster, it's easier. We're not going to look at what speech did because speech didn't go over anything with us, and I don't want anybody to choke. So they saw that there was no change in the resident, regardless of what therapy said the resident can do, and between and that and what we said the resident was able to do based on their ADLs. So definitely we want to keep looking at that, and restorative allows us to do that. It's an opportunity to establish the RNP by therapy. So I know I said therapy does not have to be involved, but my philosophy on that is it is a nursing program. However, we need to know that the resident is safe to perform the restorative nursing program services. So I like to refer the resident. I always recommend to refer the resident to therapy. So we're noticing a tightness in the resident's shoulder. So when he goes to put on his upper extremity clothing, when he goes to shave, when he goes to wash his face, his shoulders are tight. He's complaining of pain. Sure, I could medicate him and just keep going, or I could refer the resident to therapy. I know it's in the shoulder. I'm referring the resident to therapy, and I'm telling therapy the resident can't wash his face without pain, can't bring his arm up over his head to comb his hair. He's having trouble with pain when he's shaving himself because of the shoulder. So now I could start a restorative nursing program for range of motion, but do I know what's going on with that shoulder? No. So I can refer the resident to therapy because that's what they do. They can check the resident's range of motion, the resident's mobility in that shoulder, and they can measure it and they can determine what's going on with that shoulder. Or they can say, I think we need an x-ray, or I think we need an MRI of that shoulder before we do anything more. So they may not treat until they get an x-ray or an MRI. And then if they see what's going on and it's okay to treat, then they treat. When they're finished treating, they establish a restorative nursing program for range of motion. And then we continue it with our restorative nursing program. But the time that they were in therapy, now the resident is safe. So we're not going to pull something in their shoulder, give them a rotator cuff tear or tear a ligament in their shoulder because we just went ahead and did that restorative nursing range of motion program without having therapy take a look at it, without doing any other diagnostics to see what's going on there. But we get that Part B therapy that reimbursement because the residents referred to therapy. We're also looking at those evaluations, increasing our Part B evaluations. And there's an increased opportunity for rehabilitation low as a rug category. When we look at our long-term residents, and we're still using the rugs for our long-term residents for CMI, but when we look at our long-term residents, a lot of them don't have a lot of medical needs. They don't have nebulizer treatments or IVs or ventilators or suctioning or tracheostomies. They don't have those kinds of things. So when we look at our long-term residents, we're looking at what increases their CMI. It's going to be the rehabilitation. And rehabilitation low is a good way for therapy and restorative to be involved together. And they have to be. Otherwise, we don't achieve the rehabilitation low rug category. It also gives your CNAs an opportunity to be creative and to get involved with the plan of care for the residents. This is one of those areas where when I talk to CNAs in terms of retention and I ask them, how creative can you be with the care of the residents? I usually get an eye roll and they usually say, yeah, with toileting, I can be real creative. Okay, but what other things are you doing with the residents? Well, toileting, transfers, walking, eating, that's pretty much what I do with them. Sure, absolutely. But when we look at some of the things we can do with restorative, and we can be creative with restorative, this is where we can ask our CNAs, help us to develop, help us to come up with the interventions for the restorative nursing treatment program. It's not old school RNP. What can we do with it? So when we're thinking about lower extremity range of motion, what if we did a kickball game? What if we got 8 residents, 4 on one side, 4 on the other side, and we had one nursing assistant with 4 of them and one nursing assistant with the other 4 of them. So now they're doing range of motion for lower extremities, active range of motion for lower extremities for 4 residents at the same time. So when we're looking at that, that's great. We can do that. And the residents can have fun. Your CNAs can have fun and they can be creative. So we can do kickball for those of you who are saying, how is that range of motion? Well, if I go through the planes of range of motion, I can kick the ball up. I can kick it to the left. I can kick it to the right. I can kick my foot down. If you do that in your seats while you're listening to me, what is your hip doing? What is your knee doing? What is your ankle doing? Even your toes, what are your toes doing? So you're getting that movement of your joints and you're going to the left, to the right, down and up. So we're getting that active range of motion. They can be creative with these things. They can do a lot of fun things. Turn on some music. It can get them involved and it can help to retain your CNAs. It becomes a team effort between the CNA and the resident. When the resident says, I don't want to do exercises, okay, what do you want to do? So it's asking the resident, what do you want to do? What matters to you? What's an important thing to you to be able to do? And if the resident says, I want to shave, we can come up with a grooming program for you. But in order to be able to shave yourself, you've got to move your fingers. You've got to be able to move your wrist joint, your elbow joint, and your shoulder joints, probably your neck joint as well as your torso. So we're going to do some active range of motion too. And now I'm getting 2 restorative programs, active range of motion, as well as the grooming with the shaving. But the resident feels good because it's not exercising anymore. It's leading him to be able to shave himself. And that's what he wants to do. And once he accomplishes that, we triage it. And so the CNAs can be creative. You're not going to do exercises. We're not going to have you lifting weights or pulling on TheraBand. What do you want to do? And let's work on that. So let's talk about quality measures and the positive impact of restorative nursing treatment programs on quality measures. Our quality measures are part of the 5-star rating system. It's one of the 3 items. It is the item that is weighed the least. So it carries the least amount of weight in our 5-star determination. We have health inspections that carries the most amount of weight. And then we have our staffing, which carries the second most amount of weight. And quality measures is the 3rd, and it carries the least amount of weight, but it is included. Now, the other thing with quality measures and our carecompare.gov is consumers go on that site and they're looking at your health inspections, your staffing, and your quality measures. So we want to look at those as well. So how does our restorative nursing program have a positive impact on quality measures? Well, first of all, what goes on the MDS is what impacts our quality measures. So let's get that restorative into our MDS. And as I say that, just to be sure that there are items in the RAI manual, the Resident Assessment Instrument Manual, that tell us what we need to have in place in order to count restorative nursing treatment programs in our MDS. So we can't count it there unless we have all those items in place. I think there's 5 items that we have to have in place before we can count it on our MDS. Quality measures are also used by your surveyors to determine greater than 50% of the sample that they're going to use during your survey. So they're pulling greater than 50% of your sample out of that quality measures. Let's have the best possible impact on those quality measures that we can, because that's going to help us in our survey. So which of our quality measures are impacted by restorative nursing? How about pressure ulcers, pressure injuries, losing too much weight, um, experiencing one or more falls, falls with major injury, symptoms of depression? There are other quality measures, the ones related to ADLs, the ones that are frozen now, the residents' independence decreased, ability to move independently decreased, and that the residents' need for help with their ADLs increased. Those have been frozen. They're going to be unfrozen very soon, but they impact those as well. So if you're thinking those two, when I think about those 2 quality measures, I immediately think therapy. And then I think after therapy, it goes to restorative nursing. But let's talk about each of these. So let's talk about pressure ulcers and injuries. If my resident is immobile, what's going to happen to their skin? They're putting pressure on their skin, usually on a bony prominence. Think about, let's start with the chair, a resident sitting in a wheelchair. What are they putting pressure on? Those of you who are sitting while you're listening to me this morning, you've probably moved around about 20 or 30 times already, and we're only a little bit past halfway. You've probably moved around a lot. Your residents who rely on staff for help to move around can't do that. So they're putting that pressure on their ischial tuberosities, which is the bones that are in our behind. They're putting the pressure, which puts pressure on the skin. So that's the buttocks. We now have pressure on the coccyx. We have pressure on the sacrum. If their elbows are resting on the armrests of the wheelchair, that's a bony prominence. They have pressure there. If they have a kyphosis, that's pressure on their spine because they're leaning against the back of the wheelchair. If they're right up against the backs of their knees are right up against the seat of the wheelchair, that's pressure in that area as well. And if they're pushing their heels into the footrests of the wheelchair, but they can't move themselves around, so they can't change that position. So they're putting that pressure on their skin at their bony prominences and other places. And now it's increasing the pressure on the skin. What happens there? It can lead to pressure injuries and pressure ulcers. Again, think about when you've been immobile after a surgery, or when you haven't been able to move for whatever reason, when your hand falls asleep or something like that. We can teach with restorative nursing programs, we can teach the residents and we can help them with weight shifts in their wheelchair. So the resident doesn't have to stand up. Standing up is great because it's putting weight on their long bones. So that's a good thing. And it completely takes the weight off their coccyx and their sacrum and their buttocks and their ischial tuberosities. It takes the weight off all of that, gets them up out of the chair for a minute or two, and then they can sit back down again, and even their kyphosis. But if we just teach them the weight shift, lean to the left, lean to the right, take the weight off those areas a little bit and lean for about, and don't lean too far because we don't want them falling out of the chair. But we can do this with restorative nursing programs. We can work on bed mobility. How many of you lay down in bed at night and stay in one position? You don't move around, you don't turn, you don't try to adjust yourself. I can't see any of you, but I'm going to guess most of you are going, yeah, no, that doesn't happen. Absolutely. Doesn't happen with me either. However, with our residents, they're feeling pain, or their skin isn't the same as ours. They're not as young as we are. Their joints and their bones aren't as young as we are. So again, they might want to be adjusted in bed, but if they can't do their own bed mobility, they're stuck. And again, the opportunity for pressure ulcers and pressure injuries. But when we're looking at that, they're stuck, so they're not able to move. So we can work with restorative nursing on bed mobility. So they can move a little bit and they can take, if my skin is starting to feel red and hot on the left hip, I can move that hip a little bit and get some of that pressure off there so I don't get a pressure ulcer or a pressure injury. What does this do for the facility? It reduces the cost for pressure ulcer and pressure injury treatments. Have you looked at the cost of your medical supplies and some of the costs for those pressure ulcer, pressure injury treatments? Yes, we can keep some of the dressings on for 3 days, but the cost of that dressing, way more expensive than what we used to use, even though we changed it daily. And we're getting better. We don't want to disturb the pressure ulcer by changing it daily, but the cost is significant. It does a much better job, but the cost is significant. So we want to look at that cost, not to mention the staff having to do that treatment, spending the time to do that wound care, to take care of that pressure ulcer, and it's hitting our quality measure. We do have to report this on our MDS. We do have to document about it. We're documenting about the treatments. We're documenting about what the pressure ulcer or the pressure injury looked like. Do we have a wound team in our facility? Do we have somebody who comes into the facility once a week, a wound care physician or a wound care nurse practitioner who are making rounds? Yeah, we got to look at that as well. And then increase Part B billing with the collaboration between nursing and therapy. Hey, this resident is unable to do wait shifts. So can you set up a program and we'll follow it through with the resident? Unplanned weight loss. These residents who are not mobile, again, think about yourself when you're not mobile. You're not hungry. If you've been just sitting around and doing nothing, you're not hungry. But if you've been out working in your yard or working in your garden or painting or whatever else you're doing, cleaning the house, when you're finished, you're hungry. You want something to eat. Residents who are active and mobile, they build up an appetite. We don't need to give them supplements. They're going to build up an appetite by being more active, being more mobile. Just with the restorative nursing programs, you're going to see an increase in how much they're going to want to eat. You're going to see an increase in their appetite. You're going to see an increase in the resident wanting to eat more because they're more mobile. When they're starting to do more for themselves, you're definitely going to see that increase and that decrease in unplanned weight loss. And you're going to see that cut down on the supplements that you're having to spend. Those supplements that we give between meals and the supplements that we give with MedPass. And then sometimes we see that the residents are over supplemented and then they don't want to eat. So it's a vicious cycle, but they're not cheap. Those supplements are not inexpensive. So again, we can also implement a restorative nursing eating program to assist the residents. And there's a myth that says you cannot implement a restorative nursing eating program unless the goal is for the resident to be independent. And that's not true. We can work with the resident to increase to 25% independence, to 50% independence, to 75% independence. Whatever it is, we can work on helping them to use their adaptive equipment, helping them to be able to cut their food, helping them to be able to open their food. Those are all parts of a restorative nursing program. How many times have you had somebody open your milk carton for you? How many times have you had somebody cut your meat? How would you feel if the next time you went to a restaurant, the server came over and cut your meat for you? Exactly. It takes away your dignity. It takes away your self-esteem. It takes away your independence. So the more our residents can do for themselves, and we can build this into an eating program, and the more the resident can do, the more they're going to eat. Also, we're going to be able to see, again, if they're eating and it's not a functional thing, that they're able to get the food to their mouth and they're able to increase their independence with eating. Are we now seeing that it's a chewing problem or swallowing problem? And then back to that Part B therapy, let's refer them to speech therapy. Also, think about the waste of those supplements. How many of those supplements aren't even used? We pour them for the resident, put a straw in it. The resident takes their medications. We come back in 2 hours and it's still there. And the resident says, you might as well throw it away because I don't want it. And again, how much do they cost? And how many times do we end up doing that? If the resident maintains their weight and the resident doesn't lose weight, remember that if we have less between the skin and the bones, there's not that fat in there to cushion the area between the skin and the bones, we're less likely or more likely to get a pressure injury or a pressure ulcer. So increasing their weight and keeping them active so that they want to eat more is also going to reduce the pressure ulcers and injuries. And we're tying two together here. The percent of residents experiencing one or more falls and the percent of residents experiencing one or more falls with major injury. Well, you can't have a fall with major injury unless you have the fall. So again, looking at our residents, if we can help them to be more independent safely, so we're not just going to increase their independence, we're going to do that safely. So it's not just therapy saying you can walk between the parallel bars here in therapy. You're doing a great job. So the resident gets back to the unit and thinks, I can get up and I can walk. I can walk to the bathroom because my bed to the bathroom, I'm the closest bed to the bathroom, is about the distance of the parallel bars. So it's a double-edged sword for therapy. But we're working on that on the unit. We're also working with the resident in a restorative ambulation program. So we're talking to them, we're walking them through them, we're educating them on it. So they're going to be more functionally mobile and they're going to be safer. Not to mention your residents with a diagnosis of osteoporosis and osteopenia. As they put weight on their long bones, they're less likely to have a stress fracture on their bones because they haven't been putting weight on their long bones. And then they do and they have that fracture. So now we're helping them to get up and put that weight on their long bones, get up and move. So they can have a restorative walking program, a restorative transfer program, and a restorative bed mobility program. And all of these are going to keep our residents safe. Where do our falls occur? In and out of bed with transfers, while they're in bed and they fall out of bed, or with walking, the resident falls. So these are the programs that are going to help our residents to be safer and more independent with their walking, transfers, and bed mobility to try to prevent these falls. And even if we just help them to strengthen, and I've had folks say, okay, so restorative nursing, the resident now doesn't fall 5 out of 5 times. They only fall 2 out of 5 times that they get up without using their call light. Still better. It decreases the chances. I know that doesn't sound right, but it decreases the chances of a fall with major injury. Even with minor injury, it decreases the chances. The more comfortable they are with getting up and moving, the safer they are with us talking to them about how to get up and move, the safer they're going to be, even when they don't comply and use their call light. They're still going to be a little more safer if we're going through that with them on a daily basis, every day, every shift in a restorative nursing program. Again, decreasing the time we spend on event reports, less likely to have to do a reportable to the state. We don't want to do a lot of reportables to the state. That's going to cause them to come into our facility, and we don't want that to happen either. So, because once they're in our facility, they can look at anything they want to look at. So it decreases the time for reportable events. It decreases the rehospitalizations because of the major injury. And remember, the major injuries are not just a large laceration. They are a fracture. They are a subdural hematoma. They are a dislocation. They are of loss of consciousness. So these are the major injuries. Less time spent calling physicians because our resident fell and calling the resident representatives and getting them angry or them saying to us, well, why don't you just medicate them? Why don't you just tie them down? Why don't you put their bed against the wall? All things that we know we can't do. So we can't use chemical restraints or physical restraints to keep the resident from falling, but we can use restorative nursing programs to help the resident. And less downtime for the residents because when they fall, they're not as functional, they're not as independent. Symptoms of depression, we've already talked about that. The more mobile they are, the more they're doing for themselves, the less of a burden they feel like, the less antidepressants we're going to use, the less time we're going to spend in our gradual dose reduction meetings, in our GDR meetings. So our physicians aren't going to have to look at those antidepressants and reorder them. We're not going to have to spend time in the GDR meetings. And we're not going to have to watch for those adverse effects because they're not on the antidepressants, because they're not feeling depressed, because they're more functional, they're more mobile, and they're doing more for themselves. The positive impact on our CMI for our Medicaid reimbursement. CMI is now a part of our Medicaid reimbursement again. We've always had the CMI, but now it's a factor. It's a big factor in our Medicaid reimbursement. So now it's only applicable to 4 categories, 4 RUG categories. Reduced physical functioning, that's the RUG that begins with a P. Impaired cognition, the RUG that begins with an I. Behavioral, the RUG that begins with a B. And rehabilitation low, it begins with an RL. So we're just looking at those 4 categories. Those are the only RUGs where restorative nursing has an impact. And it's a small impact. It has to be coded on the MDS in section O, or it's not going to have any impact at all. The positive impact is minimal per resident. Remember, your CMI is comprehensive. You're not getting paid like with PDPM skilled per resident. You're not getting the reimbursement per resident, what's going on with them. You're getting that comprehensive, that everybody gets paid the same amount. So when you look at, and this comes right from, and this is just the reduced physical functioning category, look at that difference between a PA1 and a PA2. PA1 says we did not have the restorative nursing to make a positive impact on our CMI rug, our rug for CMI. PA2 says we did have the restorative nursing that we needed to have in place to make a positive impact on our rug category for our CMI. Well, when you're looking at that, you're saying, okay, a 0.48 to a 0.50. How much of a difference is that going to make? For one resident? Absolutely none. I will tell you that right now. Absolutely none on your Medicaid comprehensive CMI. But if all of our residents who are in those reduced physical functioning, behavioral, and impaired cognition rug categories, if every one of them had the restorative nursing that would get us to the something, something two, rather than the something, something one, it would have an impact on your CMI for Medicaid reimbursement. Comprehensively, it does have an impact, not to mention all of the other places it has an impact. We've talked about the skilled and the PDPM and how it is included in the PDPM. Where it impacts you is under the nursing component. We have all those components. We have PT, OT, speech, non-therapy ancillary, and the nursing component. Where restorative nursing is included is under the nursing component. Again, it's a nursing treatment. It's a nursing thing that we're doing with our residents. It's got to be coded in the MDS in section O. So this is again right from CMS with the PDPM. So what you're looking at is, and if you go to the right of the screen, you're going to see two or more. Looks a lot like what we just saw under CMI. I have two or more restorative programs. It's going to make a difference in my CMI. If I have not enough, I don't have the two restorative programs, it's going to keep it at, if I was at 0.99 and then I added two restorative nursing programs, it's going to bring that up to 1.04 under the nursing component. It makes a difference. And PDPM is per resident. The positive impact on survey, I mentioned early on about the federal regulation F684, quality of care. What does quality of care ask us to do? To help the resident attain and maintain the highest level of physical, mental, and psychosocial functioning. That's what we can do with restorative nursing. This regulation was most frequently, it is the regulation that was most frequently cited in Pennsylvania in 2023. Just looking at that 1 year, just looking at our state, it was cited 542 times in 1 year. Yes, we have a lot of nursing homes in Pennsylvania. That's a lot of citations. It was cited at immediate jeopardy twice and actual harm, which is G level or above, 16 times. So yeah, let's try to do this. Let's try to not get that deficiency and get that restorative nursing program in place, because we don't want that immediate jeopardy. We don't want those deficiencies. We don't want that to impact our health inspections on our 5-star quality rating. We want all of these things to be positive for our facility. So again, you can see here what the intent is, and I pretty much read that to you. Other federal regulations that can be impacted by restorative nursing programs. F686, pressure, ulcers, and injury, not to mention your quality measures. F689, accident hazards, supervision, and assistive devices, making sure the resident is safer, making sure the resident has the appropriate supervision for what they're doing, and the assistive devices to do all of these functional mobility and self-care tasks. F744, unnecessary medications. We talked about the depression, the pain medications. F692, nutrition and hydration maintenance. How many supplements are we giving the resident? How much weight is the resident losing? F561, residents' rights and self-determination. What if the resident tells the surveyor, I want to be able to shave myself and nobody even cares. Nobody's letting me do that. They just come in and shave me. They don't care. Or I go 3 days without a shave. Okay. F6, and again, back to restorative nursing, ask the resident what matters. What do you want to do? What can we work on? You don't want to do exercises? Fine. I don't like doing exercises either. I don't like to go into the gym. And think about your residents at their age level. How many of them went to the gym? F656 comprehensive care plans. Restorative nursing has to be care planned. But when we look at the care plan and we see all these other things going on with the resident, how do we impact those items? Yep, all of the things we just talked about. And this is just to name a few. The other thing that restorative nursing programs allow us to do is to build an age-friendly health system. Again, what matters to the resident? We can address the 4 M's of care. What matters to the resident is really important. We allow them to drive their care. We allow them to tell us, when do you want to do your range of motion? When do you want to move those arms around so you can start shaving yourself again? When do you want to, if they like exercising, when do you want to do your exercises? When do you want to this? When do you want to that? And again, if the resident says, I don't feel well, can we do this later on? We can do it on the evening shift. There's no reason why we can't. It's not special or specific to the day shift. It's what matters to the resident. Medications we've just talked about. How do we decrease pain meds? How do we decrease antidepressants? How do we make sure that the resident doesn't need these? Mentation. Keeping the resident from getting depressed, keeping the resident oriented, not going to the hospital and coming back disoriented, and being a part of their care and their mobility. Everything that looks or sounds like restorative nursing ties back to mobility and self-care. So that is the end of our review today of the Restorative Nursing Program. I am Sophie Campbell, and I am the Executive Director for PADONA. It's been my pleasure to spend some time with you this morning. Are there any questions?
Thanks, Sophie. I'm taking a look at the chat feature. I'm not seeing any questions that came through, but as a last minute reminder, if you want to pop a question into Sophie or myself before we end today's webinar, please feel free. If you're a little camera shy, no big deal. You can also reach out to me via email or Sophie. Sophie, if you go back to that slide you were just on, Sophie's email is there highlighted in pink text. Like I said, please feel free to reach out to us. We'll be happy to answer any questions you might have that perhaps come to mind after we end today's session. And Sophie, as always, thank you so much. I hope everyone found some value in today's session. I know I did.
Thank you so much. It's been my pleasure to do this. I appreciate the opportunity with PHCA and with all of you who are attending today. Thank you and have a great rest of the day.
Thank you.